I'm here in plenary session, real life edition, and I'm sitting on the couch of Dr. Eric Collission. Professor Collission is a professor of medicine here at the University of California, San Francisco. He's a medical oncologist, he's a GI cancer expert, and he is also a physician scientist, runs a lab. And it's a pleasure to get to talk to you. Thank you so much for taking the time.
Well, thanks for inviting me and coming over to do this.
I've heard a lot of good things about you. I hear from the fellows that you're a great raconteur, and I also listened to your recent talk in the Friday morning sessions, and I thought it was terrific. And maybe I'll ask you about that in a little bit. But I guess first I wanted to ask you a question just about, if you could maybe explain to the listeners a little bit about how you wear the two hats of physician scientist, how you divide your time between clinic and lab, and what your lab focuses on.
Yeah, happy to. I've been at UCSF since fellowship, so now over 15, coming on 20 years.
It's a little closer.
And I've always been fascinated by science. I like to say I took the expensive full cost route to being a physician scientist, in that I didn't actually get an MD PhD in medical school. I went to UCLA and paid full freight rather than having it paid for by our government, and recently completed paying off my loans, by the way.
Wow, just in time for the forgiveness.
Just in time. No water under that bridge. But anyway, So took a year off in medical school and got to go to the NIH with the Hughes program, which was really transformational, and did a year after medical school of more research I had started, and just kind of never considered not being in the lab after that. And it was almost too late in my educational game to realize that I maybe should have gotten a PhD and done things differently. But I kept pushing forward, and now have a one clinic a week that often goes to a whole day, and the rest of the time's in the lab.
In the lab. And your lab focuses on a number of things, but would it be fair to say pancreas cancer is on the top of your list?
Yes. So we, in the lab, we try to intersect tumor genomics, that we used to get from TCGA and kind of rarefied data sets, but now get from just real life patients in the clinic every day, thankfully. And then intersecting the power of mouse models to actually take rarer variants that are not kind of the canonical disease model in disease X or Y, and use the mouse to kind of compare what different driver oncogenes or tumor suppressor genes do in the context of essentially isogenic animals. So all other things are the same except for the oncogene, which is, as you know, not the case in patients, where different oncogenes, different mutations actually co-segregate with all sorts of different things, certainly diseases, but also things like smoking history and age and other variables that make it hard to interpret. Does mutation X respond better than mutation Y because the drugs are more potent, because the patients are older, because the immune system's more robust? So the mouse has the ability, at least in theory, this is how I write the grants, to clarify those questions. And ask, really what is the contribution of the mutation itself versus the genome in which it occurs, versus the host in which it occurs, and all those. So the lab is about half pancreas cancer and half lung cancer, actually. And the reason for that is I love lung cancer as well. And earlier, when I was at the VA, I got to see lung cancer patients. I've had to simplify my clinical life a little bit there, but that's a bit of an efficiency of the mouse house, where a lot of the alleles we use are common in pancreas and lung, and a lot of the biology is similar, but a lot's different. So that keeps me on my toes, trying to keep up with that, those two clinical laboratory intersections.
It's really interesting that you talk about those two malignancies side by side, because I think many people will think of lung cancer as sort of the hallmark disease for which we have learned of numerous oncogene addictions, and maybe have 8 to 10 different driver mutations for which we have drugs, and maybe 20 different drugs or more. And pancreas cancer has been so elusive, and I guess aside from BRCA and homologous recombination deficiency and olaparib, hasn't had the same sort of.
Right.
So, I mean, is there an explanation for that? A biological explanation? Is that still work under progress? Why is it that lung cancer
Yeah.
is falling that way?
Yeah, no, that has been really my question since I got into this business is the discrepancy between the Lazarus-like response of a lung cancer patient to an EGFR inhibitor versus the recalcitrance of a pancreas cancer to really many treatments. Is that just not finding the right drug, or is that some important difference about a cell of origin being different in the pancreas or different in the lung cancer? And it has been convenient to say, well, we just don't have a good RAS drug yet, and when we do, it'll all be different. And now we actually do have
Right.
some of those drugs, and we will see if it is different. I think my instinct is that we're going to learn that pancreas cancers can't live without RAS the way that EGFR-driven lung cancers can't live without EGFR, and they will go through all sorts of hoops to either repair that defect invoked by effective drugs or find ways to escape it that are off target, so to speak, or kind of state changes as we're referring to those. So I do not think that they differ, but my bias is what I told you that I do 80% of the time. It is the exact same allele, the KRAS allele that we put in the pancreas or we put in the lung, and those mice do not do well in either scenario. And many of the attributes are the same. You don't need a lot of other genomic alterations to occur to have a lethal lung cancer arise in the mouse from just turning on KRAS in the lung. And likewise with KRAS in the pancreas, using a little different genetic trick to get it to turn on. So by many criteria, they are quite similar in that they are caused by KRAS. It is sufficient. It appears necessary by all the criteria we use. And I think we're learning that model's been extremely helpful, but also rather narrow, in that it's just been one allele. It's been the G12D allele in KRAS, which is the most common mutation in pancreas, not the most common in lung.
Right.
And we're learning all sorts of things about the potency of these different alleles, irrespective of their amenability to drugging. That just the natural history of a lung cancer with a G12C is different than that with another RAS mutation. And I think we will soon see. I'm quite encouraged. Exactly the answer to your question is, how addicted is a pancreas
Right.
cancer to that oncogene, or is it just as in colorectal, where it appears to be a modifier at best and dispensable in a lot of things. So that's why we're in this business. It feels like the right place at the right time.
Well, it's an interesting time to be there. Obviously 10 years ago without RAS drugs, but now we have so many in the pipeline, and be very curious to see what the response rates are.
Yeah, it has felt like I was sharing with a colleague that we've been wandering the desert for a few generations in pancreas cancer, and it feels really exciting to kind of see some shimmering clouds on the horizon that may be water. So we're enthusiastic about what's coming.
That's a good place to be. Now, I have to ask you this question as a physician scientist and a physician scientist who's attained the rank of professor, which puts you in a smaller and smaller cohort. People tell me that being a physician scientist in this modern ecosystem is like working in Goldman Sachs. They hire 100 people, and there's only one job at the end of the day. And the whole thing is about winnowing down to that one job. And, any way you look at it, from every statistic I've seen from MSTP funding, and you follow the long-term trajectories of people, I think a good chunk of those people, and you didn't do the MSTP, you did it the harder way, but a good chunk of MSTP people will stay in the academy. But they don't always continue to have continually funded laboratories.
Yeah.
And it really does seem like a slog. And so I guess maybe two questions. One, if you could talk about, has it changed in your career? Is it harder or easier? And then also I'm really curious for you, what was the hardest moment in your training? Was it the first fellow to faculty transition? Was it the first R1? Was it getting that first continuity? Was it when the startup ran out? What was
Right.
the hardest moment?
Yeah, no, that's a great question. I was speaking to a younger hire today about this, who's more clinically focused. But my my one of my mentors and friends down the hallway here, Frank McCormick, gave me good advice early when I was thinking about finishing fellowship, but hadn't really done a ton of productive laboratory research at that point in during clinical fellowship, where you kind of don't do anything but care for patients, and was thinking about going elsewhere, looking for a job elsewhere or not. And Frank told me, he's like, you're never a hero at home, but you're doing good work. Keep it up. And that was a really important decision in retrospect of whether I should, stay at the institution where I'd kind of learned the good and the bad, where the bodies are buried, but also the great resources and the doors you could knock on. And necessarily maybe take a little lower number in the startup and maybe a little less of a footprint than the red carpet that would be rolled out elsewhere.
This was fellow to faculty transition.
Fellow to faculty, exactly. But where you were probably going to be left to your own to figure out where the men's room was, which is the good mouse house to be in, and which one has pinworms, and all these things you only learn after, really being in an institution. I chose to stay and was wonderfully supported by people here, Margaret Tempero, Alan Vanook, and others who I, couldn't have done any of this without. That was a hard time, because it's hard to make other people move on the same schedule you want to move on. And, academia and institutions are kind of big and slow, and they need to be, because they need to be around tomorrow. And 25 or 30-year-olds with young kids and things often have exigencies that are more acute, and you kind of need a salary, or you need to know, should you buy a house? That was I won't say scary time, stressful time, about was I going to get a job or not, and would it be enough to pay the rent. The other transitions that were big were kind of internal promotion and external funding, and those are, I think, always the two. They often go hand in hand, and I got pretty lucky on an early R01 that I got before my KO8 ran out, which was really took a lot of pressure off that kind of first big grant. And I spoke to someone in that study section now, 10 or 12 years ago, 10 years ago. And this reviewer would obviously never divulge anything discussed, but, you don't have to have a perfect score as a new investigator to survive. You got to be good enough to get the grant, and it is easier to get that first grant with the new investigator status. And it is a series of, making it below the pay line, and you don't get extra money for a 1% grant.
I see.
So I learned early to just keep resubmitting things if you thought it was work you wanted to do for 5 years. And if it got to the point where you didn't want to do the work, even if the grant was funded, move on, because that's also not great to have a grant with a body of work that you've been spent 2.5 years resubmitting and fighting with people about, and you actually don't even want to do it anymore.
I see. Some people advise to take the money and then do what you want instead. But you don't like that.
I've had one project with another non-NIH sponsor where that was the case, and it winds up being more painful, trying to write progress reports and be, less than transparent about what you're actually doing, and trying to match it to the original aims and telling this story. It ends up being kind of more trouble than it's worth. And you don't want to have that bureaucratic downer being, the driving force of what you do. A lot of what you do as a PI that you don't do as a fellow or a postdoc is really, all these progress reports and all this. And it's if it's actually about stuff you care about and you're proud of the result and you want to keep doing it, it gets easier than trying to fit this round peg into a square hole that you proposed 3 years ago and don't actually even want to do anymore. Yeah, so I've been the internal promotion. I now have the privilege and duty of helping with the letter writing for internal medicine candidates. And that was a huge black box, and it went well for me for reasons I never really fully understood. Now I understand them being on the letter writing side. But that's one thing that I think we could do better, kind of telling our junior faculty, physician scientists or other, what is expected of them. We want you to be happy, we want you to do well, but what are the actual boxes that one needs to check to live a life in academia? And those are not just publish cell papers or get tons of grants. Those have to do with citizenship and teaching and things that it's easy to ignore, and actually not very hard to accommodate if you know about them. You just kind of, so that's one thing I would have done differently if I had known. But I would say those early kind of instructor to assistant professor, those are by far the most stressful times, and everyone has those stresses, and everyone survives in one way or another, right?
Well, I guess there's survivor bias there as well.
Yes, that's true.
Yeah. No, I mean, I think that's well put, and I think I guess I'm curious if you feel like would you say that? I mean, how much of it is the skill really being clear about the science, and how much of the skill is the skill of how to present your thoughts?
No, that's a huge question, and that is it is good, all things being equal, to have productive thoughts rather than distracted thoughts. But that first grant I got, so I went about 4 years with my lab with one R01, which my mentor, everyone told me, oh, that's great, Eric, you're doing great, you have an R01. And I'm like, yeah, but it doesn't really pay very much, and I'm burning all this money, and I don't know how this ball is going to stay in the air.
Right.
And then I got asked to be on a standing study section, and I had to read my first pile of 9 or 11 R01 submissions, which is your typical workload in study section. And I was like, gosh, this is a lot, because as you know, the application itself is 200 pages often, 180 of which are nonsense and, just budgetary things that you can't understand even if you try. So just learning how to review a grant, even just what page to read, took, a substantial amount of time. But once I was on that committee, my first review, took me a week. By the first review cycle, I probably dedicated easily 40 hours to reading these 8 or 9 grants. It just took a huge amount of time. And then I went to the study section, and you have to present these grants to your peers in a way that they can understand, and why you like it or you didn't. And I realized I didn't know what I thought about these grants. I had just read them and tried to kind of memorize part of them or recite their big points. But I realized that if I couldn't recite it after reading it for 40 hours, there's either something wrong with me or something wrong with the proposal.
Right.
And that became my, it's every 3 months, as you know, so I did this every 4 or 5 months, and I got to see the difference between a well-written grant and a poorly written grant.
Interesting.
And it is, the science that emanates from these is largely equivalent, but people who write clearly are extremely effective in getting their grants funded because there's a guy like me who's, can read. I'm fairly literate, but I don't want to beat out of you what your thoughts are when you're not even here. I'm reading this thing you submitted to me. So I very soon after that got pretty formulaic about my grants. I have rules that must be followed, and so far so good with that.
It's really well put. The way you frame it is that it's sort of like a memorability kind of thing,
totally.
Too. Right, because you're right. The person's going to be reading a stack of these things.
Why are you punishing this nice person? You're not going to know who they are. They're going to know who you are.
Right.
And why make it hard for them? Yeah. So may I go over the rules quickly?
Please.
Okay,
yeah.
so here are the rules of an R01 because a listener may actually submit one that I read. So this is what I would love to see.
Yeah.
No walls of text. That is the first rule. So if you give me a wall of text, I feel intimidated and depressed.
You mean no page break, no paragraph breaks on
No
the page.
indentations,
Right,
no pagination, no just text from
Beginning
stem to
end.
stern.
Right.
And so what does that mean? What's a lot of text? What's not? Okay, so we need another rule. One graphic, table, or figure on every page, including the aims page, excluding the references. I don't put any figures in the references. So every page has a picture. Yeah. Okay, I'm just a normal guy. I like pictures. Everyone likes pictures.
Does, yeah.
So give me at least one picture, even if it's a picture of you injecting a mouse with cells or something. Just break it up. Give me a picture. And lists and bullets. Like aims are called aims because someone wants to know what you actually hope to achieve. I don't want to explore. I don't want to understand. I don't want to discover because I don't know when we're done understanding or exploring.
Right.
I want to know in an aim when it will start, when it will be done, and how I'll know it's done. So those are the three rules. No wall of text, which is actually a negative rule. Positive is a picture on every page, and aims that have discernible words in them that are not discovering or understanding or exploring. I don't want to do any of these things in aims. I want to define, I want to demonstrate that X is better than Y. I want to define the factor that gets the signal from A to B. I
Precise
think
active verbs are what
active
you want to do.
speaking, and I think that's really helpful for reviewers to be able to advocate for you in that room, because she can, when she's reviewing this grant, she can say, hey, Dr. Smith wants to actually figure out what sits between kinase A and transcription factor B, because we don't know that, and she's shown that we don't know that, and this is how she's going to figure it out, and I think it's worth knowing, so let's fund this grant. If on the other hand, the reviewer has to say, well, she's really bright and she wants to understand this pathway in a way that's deeper, no one in the room can object to that, but it's not really inspiring. I mean, I want this woman to understand things too, but why do I need to pay for it if I'm in the grant review room?
Right. No, I think, those are brilliant rules. And I think what's interesting to me is that 2 out of the 3 rules are about the visual display of information.
It's just just don't break those rules, and you're doing okay.
Yeah.
You're not doing great.
and the third rule, I think, is a very useful rule too, which is that, memorability also means that often specific details make things memorable in the mind. And if you're just exploring all the time and elucidating and these kind of vague words that mean you're just going to run a bunch of studies, but you're not telling me exactly what you're running.
Yeah.
And it's also very interesting because, I have never formulated grant rules because I don't have, no one's going to come to me for that. But I tell people the same thing about publications and how you submit papers. And I say, the BMJ has done something interesting. You can actually look at anyone's submission. They have any paper that's published, you can look at all the history from the original submission to, and sometimes I go through and I look and I say, look at this person's, the letterhead is nice. The letter is well written. It actually explains in 2 sentences why this would be good for the BMJ. And look at how they format the response to the reviewers. It's thoughtful and visually nice. And people like that because people don't want to be working hard.
That's another huge thing. Exactly. The response to reviewers, you get those in grants too. I agree is having just compassion for your reader and, really wanting her to understand what you want to do and assuming good intentions. These are good people. They're doing this for free or $172 or whatever you get for a day. And, they really do want good work to be done, and just don't punish them with things that they can't understand. The thing with the action words versus the fluffy words is that it really is, I think, human nature that unless you understand a thing well enough to explain it to a peer, I feel a little bit stupid. I'm like, I feel kind of stupid. I don't know what she's going to do, but it was my job to know what she's going to do, and I kind of don't know. And I'm kind of a little bit angry that I look stupid in front of my peers because she didn't tell me what she wants to do in this grant. So you got to know these are humans reading these things, and they have all the same emotions you do. So I think that's been helpful. So that I apologize for the convolution here, but it is it took me a while to understand that writing grants is not about showing off or proving competency. It is about communicating.
That's really great.
And and you don't learn that till you have to be on the other side of it, or at least I didn't.
No, I mean, I think that's such a great point and a great perspective. I think people find that really interesting. There's another topic I wanted to ask you about.
Yes.
Okay, and I'm not going to name names, but it's because it's not any one person. But you know, not a week goes by these days. It feels. And by the way, I'll put an asterisk here. I'm actually curious about this question. I'm trying to empirically look at it to see if it's true. But the point I'm going to say is that it feels like more hematologists, oncologists, people in our profession, academics, are moving to the industry, biopharmaceutical industry. So we're studying right now to see is it in fact empirically true, or does it just feel that way because people are on LinkedIn and Twitter and you see where they're going more often than you used to. But we're going to study it formally to see if that's true. But I feel as if it might be true.
Okay.
I guess my question is, why?
Yeah, I have the same questions. I try to do some journaling every morning, and that was actually my topic this morning, is to like, where are people going and what are they doing? And the other part of that, which maybe will be part of your study, I hope, is who's winning. I mean, is industry getting the good ones, quote unquote, or are they getting the ones who don't want to do this anymore? And another slice of your question is, who's leaving? Is it the premier clinical investigator who can run a trial and get it done under budget and on time? Or is it the blue sky scientist who's studying genome organization in some way that it's not clear to anyone how this is going to become a piece of chemical matter in a bottle for $20,000 a month? I share your impression that I think we are losing people more quickly. I can't tell if it's a COVID thing or if there appears to be no ability to counterattack from academia. That we're just kind of, without getting political, it seems that we are overly focused on, internal mask policies and how many, who the elevator, yes, and not in the hallway. And it just feels like academia has, in some cases, appropriately due to COVID, kind of lost focus on what's important here, which is growing and retaining good people, and that, getting mired in some of these more socially important but distracting efforts has consequences. And I think one of those consequences is not supporting people as much as maybe we otherwise could internally in academia. And it's hard to counteract that with individuals. That's kind of institutional. And I don't think that we're any worse than anywhere else, but I do get that impression from a lot of people, that people come to work and there's all these, guidelines and trainings and sensitivities and things. And I think they'd rather just do their work and kind of not get involved in a political cause or a social improvement project while they're studying, chromothripsis. And so I think that's kind of gone full circle, where the liberal social politics have kind of maybe started to be a bug rather than a feature. Maybe. I think that's a factor. And the money continues to diverge, right? Everyone needs more money than they used to just to buy the same carton of milk. And salaries are not, there's always been a disparity, but that disparity is increasing, where pharma is able to go to the moon with respect to salaries, and academia hasn't been able to counter on that front either. I guess I'm interested in your question, though, and your thoughts on, do you think this is a larger commentary in that we're less curious as a society or as doctors in general? Are we beginning to assume the mantle of, we just work here, it's our job to not screw things up and, make sure they're on a statin if their cholesterol's X? Are we basically paving the way for the robotization of our profession, or is there, do you see that? Do you know what I'm asking?
Yeah. Oh, I think I guess I've really enjoyed listening to you because I feel like my thinking has been kind of along a lot of the same lines that you're pursuing. I mean, one of the avenues you're pursuing is that, we have to acknowledge that oftentimes people are moving to a job that pays more,
Yeah.
both in base salary and they're paid some in stock, which of course has tax implications that are pretty favorable.
Yep.
We're paid the old-fashioned way, where
Yep.
the tax man takes a lot of it, especially in this place.
In this state,
In
yeah.
this state. So of course that's one thing, and another thing might be flexibility, because even though as a lab scientist and I do epidemiology research, we have a lot of flexibility in that side. But when you wear your clinical hat, the flexibility goes very low
And lower every day.
and lower every day. And
Yeah.
I mean, I don't know. Somebody once asked me, like, "Oh, well, when you're sick, who covers your clinic?" And I was like, "I've been attending for 7 years. There's no such thing as being sick. I mean,
Right.
who could cover your clinic?
Right.
These people want to know your opinion. They don't want to know anyone. I mean, I can't even imagine how somebody could even do such a thing in our profession because,
Right.
we're not doing sort of I don't know, maybe a different type of specialty one could substitute.
Yeah, wasn't that odd? I think, we were all interns once. It never occurred to me. I mean, I went to work, frankly, viremic
Oh, of course.
many times, and and now that's, tantamount to kind of a war crime,
Yeah.
doing that now
Murder, yeah.
would be and I wouldn't do it, and I don't condone anyone doing it.
Correct.
But it hadn't occurred to me to stay home because I had a cold. And now one should and does. And so some of those are for the better.
Right.
I guess what I'm worried about is as we do adhere to guidelines more and we do improve things for the population as a whole, are we deselecting the individuals who want to kind of do things differently and show a different way of doing it? And it's some of this is kind of existential in nature, but I'm not sure how much creative research you're going to get emanating from people who are the best at running a clinic on time and hitting an RVU goal and adhering to, the work hours regulations. So it's not, it was tougher when I was a kid, but you do select for excellence in different ways.
Yeah.
These people are excellent at getting lots of RVUs, getting through patients quickly, and that might not be the same kind of person who discovers that, the genes and viruses that cause cancer have a human origin. I mean, that's a very profound thought that you might not occur to you if you're trying to make an RVU limit.
Sort of the varmis work, yeah.
Yeah,
the varmis
exactly.
today would. But I mean, to push on what you're saying, I would say that at least for one phenotype of people who are leaving, which I think is a pretty big phenotype, which is the clinical trialist academic. Mm-hmm. And I think one of the reasons they're leaving is, and this is different than even when I started my fellowship, is that the job description that we have created at a university, and not just any university, and the job description at pharma are increasingly the same.
Yeah.
Like you work here, maybe 60% of the patients you're going to see, you're putting on trial.
Yep.
And you're in, and then half your days in Zoom meetings with one sponsor, the other sponsor, steering committees, this kind of stuff. And you start to think to yourself, you feel like the nurse practitioner
Yep.
for the pharmaceutical company,
Right.
seeing the patient on their behalf.
Yep.
You switch on the other side, you're going to get paid more. You're still going to design and talk.
Same Zoom meeting.
Same Zoom meeting.
You're just on the other end of it.
Exactly. Same Zoom meetings.
Yep.
And then somebody else is going to see the patient for
Yeah.
you, probably the person you trained.
Right.
And and I think that what the academy, and whenever I listen to people talk, I think exactly what you're saying, which is that curiosity component. And I suspect that that's what motivates you. That's what why do I stay? Because how can I do the kind of research I want to do in any other environment? No
Right.
one will allow me. And similar, you're doing really sort of blue skies, fundamentally trying to understand this thing that's been there for thousands and thousands of years in a way that no one has ever understood it. And yes, the company might allow you to do some of that, but insofar as it's marketable and products in hand.
Right.
But for a lot of people, the university cheats the faculty by not allowing them to have that curiosity part of their career.
Right.
Because they extract every hour out of them for
Yeah.
see more patients, more RVU, run more trial, put more of your percent on. And I think that whenever I listen to some of the people say how to fix it, all their fixes are just going to make the problem worse because they just make the job description even more the same.
Yeah. Yeah, I think, we, as you know well, we lose routinely our clinical research coordinators to industry because there's a lot of industry in San Francisco. We do a pretty good job of training them, and then industry's like, hey, these people know a lot about colon cancer. Let's have them develop our drug in colon cancer, pay them 5 times as much, and that's a career. It is... we're kind of seeing the same thing with faculty, as you say, that, well, if this is just a pipeline, let's just move up the pipeline. And that is, that is concerning. I do think that physicians have been, academic physicians, and I'll say more physician scientists, lab-based people. It still is true that if I do largely the same job of many colleagues in anatomy and biophysics, our jobs get R1s. That's most of what my job is. I do get paid more than those people do, and I certainly get paid more than my professors when I went to Cal, who do very similar research as to what I do. And so we do want it a little bit both ways. Like we want the relatively higher salary than the kind of similar work. So one argument would be, well, I don't care if you have an MD. Why are you making more than a PhD who has just as many grants as you do? On the same side, there is that perceived ability to make a lot of revenue for the medical system, and that somehow justifies this. Yet, we have clinical people who are not very clinically productive, for example. We have, laboratory people who don't produce a lot of grants. And so there is some inefficiencies in the system that I think do make the economics difficult for the university, because we don't want to be firing people because they don't get their grant renewed on one cycle. That makes it tough to have innovative ideas or controversial thought. At the same time, we've left the era where you're endowed for life with a salary to think deep thoughts and produce nothing for 40 years. I think that's gone. So we're trying to find a new sustainable model, and I don't know what that is. It is hard for the physician scientist. I know that's a lot of your listener group, is this people at the intersection here, and it becomes difficult to again, if you're the grantor, you're the NIH, you're the NSF, you're the foundation of whatever. If the goal of that foundation is to get research X performed, one could say, well, the product is the research. Why are we paying more for this guy's salary than this female PhD scientist who does largely equivalent work, and we pay her 70%. So let's, so that hasn't crept in. I don't think it should. I think people, review grants largely by the people and not their salaries, which is good. But I am worried that we're going to start kind of debating salaries in different ways, and industry's forcing that, I think, in a lot of ways.
That's really interesting. I want to ask you about reproducibility, because I think it's so interesting, and there's some recent work this last year on the topic, and then maybe that'll take us to the time. But I guess maybe there's two parts to this. One part is I sometimes feel like in academics there's incentives for you to do a lot of your own work. But if you see somebody else in your space or your field publish something, and you read the paper and you find like, oh, that looks a little problematic, and that looks a little problematic, that there's actually not much of an incentive for you to speak up about that.
No.
You run the risk of offending them or insulting them, and they could be on the study section, and they could be your reviewer, and they might not be unhappy with you. And so we're all kind of producing our own content, and we don't have as much incentive to police, or not police, but at least look at and critically evaluate other people's content. And at the same time, I saw recently, at least in the basic science space in cancer biology, they've completed their reproducibility project run by this guy Brian Nozick from Virginia. And I don't know. Obviously, no two experiments are exactly the same, and so there's always going to be some variability. But this project was nice in the sense that they actually spoke to the original investigators. They had the original investigators vet the replication protocol. Do you agree? And if they make substitutions and reagents that they thought to feel like those substitutions are not going to change the result, they're trivial.
Yep.
Right. And even under those conditions, it looked like something like, only 20 to 50% could be reproduced. And this is the creme de la creme of the biomedical literature. These are the top papers. And so I guess I wonder how you think about this in your own science, because, you're somebody who I know you care about the truth. And so you don't want to be misled and mislead yourself, too, and spend your time. At the same time, there's under so much pressure to be the person who's a discoverer, to always be finding something new. And that pressure is just naturally going to lead to this problem. Mm-hmm. How do you think about this as a basic scientist?
Yeah, I mean, it is a definite. You have a different view, kind of on this side of the wall. Is that there are the factors interlab meaning between two different laboratories. There's also the kind of intra-lab dynamic. Is that I do go in the lab, and I actually did some pipetting a month ago or a couple weeks ago. But, most of the work is not done by the PI, the actual pipetting. And the, with any lab with more than, 3 or 4 people, it soon becomes impossible to really,
Police
fact check every, every image that is, downloaded from the server and rename the file and the bands. So it just becomes practically very difficult to check everything. And I think most PIs handle that with just kind of orthogonal trust metrics, like, when people apply, I'm like, oh, well, she did this paper. Was that a good paper? I don't ask anything about their work. I read their work, and I just ask confidentially, can we do a phone call off record? Is there anything that would ever worry you about this person? Mm-hmm. I don't care about their science. I don't care about their work ethic. I just care about their ethics. Right? Yeah. And that really is a bit of due diligence. It's in no way there's no incentive for that person to say, yeah, she's a horrible person and cheats on her taxes. But I think a lot of us work on that level. It's also, I look at it from the side of when I see a cool paper and I really want to say this is a great new model system, I don't really care about their question, but I want to use it to answer this question. Let's build it up in the lab and get this to work. It's extremely difficult just to get the thing to work, right? And especially if you were doing this multiple times, I worry about the denominator rather than the numerator of what is this number of reproducibility? It's clearly true, and it must be true just because of the incentives we just spoke about. You don't get promoted for not publishing papers or for telling other people that their work is garbage. You get promoted for publishing papers. So anything that has a unilateral incentive is going to produce an unfortunate amount of less than fully reproducible stuff. I'm not sure what to do about it other than having the consequences of unreproducibility be less than full and total death. Right? I mean, if you want people to self-police, you need to build your enemy a golden bridge, is what Lao Tzu said, right? So if the enemy is non-reproducibility, don't trap them in a career-ending, quagmire by saying, yeah, there's some problems with this Western blot. Give them a way to actually make it right. And so I think that is one positive step we could take as a community, is to have a way of actually being able to say, I'm sorry, this got away from me. I think it's an error, and not having it be a kind of mark of shame for the rest of your career. So I think that's one positive thing we could do. What do you think?
No, I think that's a great idea. I mean, I think that many people are averse to retractions, corrections, just because they don't want it under their name.
Right.
And maybe it doesn't have to be
and
called so putatively.
Could we relabel that, or have a more public forum where it's stuff where the postdoc and the PI get to kind of, do a verbal explanation of what went on here, or something that's less punitive than a mark of shame that they have to wear.
Revise the manuscript.
Yeah.
But I guess I think it's a really excellent point. But I mean, I want to just say, like, separate two things you mentioned. I mean, one of the problems you mentioned, that the first problem that I didn't bring up, which I think you're right, is that there's a tiny fraction of I think unscrupulous actors, and they could be at any level, from attending to like the person who spends the summer there.
Yeah, exactly.
And I'll tell you a little story offside. Many years ago, somebody wanted to work with me on a project, and like you, I don't have a great way to detect everyone. I give them something, and they have to collect all this data, and it's like a voluminous task, and then eventually we analyze the data. But the things I always do is, like, I spend a lot of time with like table 1 and the figures to just make sure in my mind that I cannot find anything like this. All makes sense,
right?
But I was working with this person, and then I just saw, like, oh, well, if this number is this number, that number can't be that number. This is this, that just can't be that.
Right.
And so then I said, I found a few things that are contradictory. You mind do one more pass and check the data? And they sent it back to me, and it had the same things.
Yeah.
And then I said, you know what, send me the spreadsheet. And I start to get into it. And then as you get into it, you just see it's sort of a house of cards. It starts to collapse.
Right.
And so I had a really bad feeling about this. But this is some person who was, like, quite productive. And then many months later, and I almost felt guilty about it. Somebody asked me, this person that they want to work with me. What do you think about it? And I just said, I almost feel guilty saying this, but like I have a bad feeling because of this problem. And this person was like, well, I don't know, maybe you're overreacting. And then like a year and a half later, this person called me and said that exact same thing happened. And
People don't change like that.
And it reminds me of like that Stephen Glass, the reporter who kind of fabricated stories,
the whole,
and Jonah Lehrer made up the quotes about Bob Dylan.
Yeah, that whole glass thing has its own name, like
Shattered Glass.
Shattered Glass,
the movie.
Yes, exactly.
Brilliant movie.
Yeah, exactly.
That's a fraction, and I think that Neil Potty and his like cancer stuff and like the early
Exactly.
part. I mean, that's a fraction. But I think what you're talking about is like that's just the tip of the reproducibility problem,
Right.
And this huge chunk of it is just honest people, being seduced by the pressures, etc. And there needs to be like we can't give everyone the same death penalty.
Exactly. And that's that's in the Twitter sphere and everything like that. That there needs to be, if someone apologizes, it should be on the menu to say we forgive you, or this happens, instead of just being banished to the outer rings of the universe forever. And I think we have to do better as a society, but I think as scientists we could do better in being more proactive and kind of welcoming people back who have screwed up. And I think we all screw up all the time, and mostly it doesn't blow up, but clinically that happens. I think it's a shame. I think clinically we would be very concerned if we saw errors in privacy or drug dosage and being chastised for bringing those up. You would want the person to learn or to fix the system that produced those things. And I think science needs to be looked at it that way. If you want change to occur, you can't exterminate the person who brings up the change or the person who made the mistake in the first place.
You're both a thoughtful scientist and also a thoughtful clinician, because the case you presented was a really intriguing a case about a patient. And I don't know, if I were to summarize it, it was sort of a case of, how do we as oncologists in those moments and diseases where the prognosis is dire, if we were to do everything and not do everything, and then the patient comes in and says, you know what, I don't want to do this. And I think in your case, and tell me if I'm wrong, you worried a little bit about, are they depressed? Are they in the right mental state?
Yeah.
And I spent a lot of time thinking about it because, part of me says, I always read these studies and they're like, women with breast cancer who report being happier are have much better survival.
Do twice as well, yeah.
Yeah, and I'm like, well, that part of that is maybe your attitude, but the other part of it might be like when the TNF alpha is pumping in your veins from like a rip-roaring metastatic disease.
Or the brain mets don't make you all that cheery.
Yeah, or the brain mets, yeah, right. You have worse disease, which is why you're not, right. So it's the disease driving the happiness and not the other way around. So I don't know. I wonder how you grappling with that. What do you think? What have you? Yeah.
That case was it was a colon cancer case, metastatic disease, first line therapy, to which the patient was responding, and actually just kind of was like, I want to take my ball and go home and don't want to play anymore, which is absolutely a patient's right. Okay. And so I guess for me, we have good treatments for colon cancer, and these patients can live a couple years, and they never live forever, right. like none of us do. And so it was really, what is my job as an oncologist? I can't pretend I never learned what depression was. I mean, I took the MCATs, I took the boards. I know you ask questions about, are you depressed? And if they say yes, they're depressed. Okay, and they might not be making the best decisions from that viewpoint. So I thought it was incumbent on me to at least explore that, and I realized that I didn't really know how to convince myself I had either treated the depression adequately, that he could make the decision properly, or do we just make bad decisions with lethal consequences all the time, and that's just within a patient's rights, which it often probably is. It rose a lot of questions for me about, how much do we need to, mentally prepare the mental health of our patients to make the best decisions about their physical health. And I really don't know the answer to that, but as you do this more and more and you become more confident that I know what to do medically, you realize more and more that you're not really treating the whole patient unless you're understanding what they're going through. And It's just an area I want to learn more, as I said in that lecture, and how we can study this kind of demoralization, depression spectrum in cancer. And it is so categorically different than, the I'm depressed because, someone's mean to me. You have a life-ending malignancy, and we know you're going to die of it, and we also have a treatment for it for now. Mm-hmm. And I don't know what the right answer to that is. It's a really, in this point in my career, it's something I'm being more attuned to or trying to.
I think that's really well put. And I think that's the beauty of oncology, is that you're always kind of finding these puzzles at the intersection of humanity and death and life and medicine. And that, even decades into your career, you find a new puzzle.
I mean, my kids talk to me about that. They're like, how can you, all your patients die? Like, they don't all die, first of all. And second of all, I mean, we as a society just don't get to talk about dying ever.
Yeah.
Right? We can't talk about it with our wives or our parents or our kids, or and yet we get to have those conversations. And it really is this kind of ancient privilege that very few people get to have. Even primary care doctors don't really get to do this as much as we do. It's a very, for certain types of people like us, maybe, I think we look at it more as a privilege than a burden.
I totally agree, and I'll come back to that in a second. But the thing it reminded me of is, like, I don't know, sometimes I feel like you're always kind of figuring out how much of the spectrum do you want to be on the, I present the patient the risks and I present the options and I, inform them and let's see what they decide for themselves, versus I make a recommendation for a patient. I counsel a patient. I get to know who they are, and I say, for you, for the kind of person you are, this is, what I would recommend. And for me, I don't know, many years ago, I was taking care of somebody, like a 20-year-old person with like stage 4 Hodgkin's lymphoma. And, obviously they're in a lot of pain, but this is Hodgkin's. And so, cure rates are high. And I was in Oregon at the time, and the person asked for a referral to the Death with Dignity program. And I was like, Death with Dignity, which is the program where that if 2 doctors agree that there's a limited life expectancy, they'll give them pills to take home, and they can
phenobarb and fentanyl or whatever.
Yeah. And I had a lot of moral anguish. And and ultimately, maybe people will disagree with me, but I felt like it's not my role to make that recommendation just yet. And I spent a long time to try to pinpoint what was it about ABVD that was so unpalatable, or that and then ultimately, we didn't make the referral. The patient went through treatment, but it was that moment where, every once in a while, sometimes a trainee who feels to me like they got too many consults, they're hurried. They say, "Well, this person doesn't want any treatment at all," so we just sign them off, cross them off the list. And I say, "Don't
hold
go
on,
hold on."
It is. And exactly. When you're rounding and there's 12 consults, you're like, well, this guy isn't buying what I'm selling, so I can go sell it elsewhere. And that is a survival skill. At the same time, we do need to understand the mental state. I don't know what a quote correct mental state to be in is, and it is it is telling, though, in your ABVD Hodgkin's case, that option would not be available were the diagnosis, something else, osteoarthritis, right?
Correct.
So
Correct.
There is some, to me, there feels like some responsibility. The reason this law is for people with serious diseases is because they do get the input of people who talk about them seriously. So I think part of that serious discussion really does try and get them to be in the spectrum of treatment. At the same time, we all have people with religious beliefs who refuse, infusions and therefore can't get a life-saving surgery because the surgeon won't do it without this ability. And I mean, that feels like that's their choice. Mm-hmm. It's been their choice for many years. We don't classify people with religious beliefs as mentally inappropriate. And so it all feels like a spectrum of interesting human behavior. Just fun to try to figure it out.
You're right. And I think that's the thing about it, is that maybe you're never good at it, but you're always trying to be better.
Yeah, exactly. And that is something that we talked a little about career trajectory today. And, that's something I'm really finding gratitude in that this is a career that there's a lot there, right? You can keep going deeper, and there's more and more to learn.
That's really well said. Eric Collission, thank you so much for your time. This is a real pleasure to get to talk to you about these topics. People should read your papers. I think they're very interesting. The heart of pancreas cancer, molecular biology. Thank Thanks so much for doing this.
Thanks for having me.